So today we're going to be talking about navigating menopause, what every woman needs to know. Now, menopause is a natural transition in a woman's life, marking the end of her reproductive years. Yet, despite the fact that it is inevitable, menopause is still shrouded in misconceptions, myths, and sometimes even silence. Remember our grandgrands and trying to get them to answer questions? Yeah, that just was never happening. But today, our esteemed presenter will delve into the intricate landscape of menopause, discussing its psychological changes, complexities, and practical strategies for managing symptoms. Whether you're experiencing menopause yourself right now, or you're supporting a loved one through it, this webinar aims to foster understanding and to empower you with knowledge to navigate this transformative journey with confidence, grace, and in great health. I am Dawn Lane, Program Development and Implementation Manager for the Massey Learning Institute, and it is indeed my pleasure to introduce our presenter, and I'll tell you a little bit about our presenter, Dr. Troy Gatcliffe. So Troy Gatcliffe is a Trinidadian gynecologic oncologist practicing in Miami since 2010. He earned his medical degree from the Royal College of Surgeons in Ireland and completed a residency in obstetrics and gynecology at Boston University Medical Center. Dr. Gatcliffe then joined the faculty at the University of Texas Southwestern Medical School before completing a fellowship in gynecologic oncology at the University of California Irvine Medical Center. As an early adopter of robotic surgery, Dr. Gatcliffe has considerable experience and expertise in this minimally invasive surgical technique for all complex, benign gynecologic diagnoses. He provides comprehensive care, including surgery and chemotherapy for all women's reproductive cancers. Dr. Gatcliffe has a strong personal interest in caring for patients from the Caribbean. He has traveled and lectured extensively throughout the West Indies and worked with both public and private sector physicians in several island nations to raise the standard of healthcare for women with gynecologic cancers. His mission is to provide exceptional patient-centered consultations to women of South Florida and the Caribbean. His areas of professional interest include surgery, clinical teaching, palliative care, and clinical trial enrollments. Wow. So it is indeed my pleasure to warmly welcome Dr. Troy Gatcliffe. Doctor?
Good morning. Everyone can
Morning.
hear me, yes?
Yes, we
Great.
can.
Okay, good. Yes, we had, sorry for the delay. We had some technical issues, as Dawn mentioned, but I think we're going to be off to a good start. So I have shared my presentation. Can you guys see the presentation?
Yes, we
Yes?
can.
Great. Okay, good. I am new to Teams because I mostly do these presentations by Zoom, so I apologize for the technical issues. So it's quite a pleasure to be here. I'm really excited to chat with you guys, and what I'm hoping more than anything, rather than going through lots of slides and lots of data, is really to facilitate a discussion and answer your questions. So I think most of our time should really be dedicated to feedback coming in from the 94 attendees that I see on the count, and really getting into a discussion where I can answer for you questions that you may have. I do have a few slides of data that I just wanted to share with you, some just very basic things. But I'm really hoping that most of what we can do is really have an open discussion. You heard about my background. I'm in Miami in my office, and I also work in Grand Cayman at Health City, which is kind of where I'm kind of coming to you from, because Health City is my new practice that I started in Grand Cayman last July. And hopefully a team from Massey will be coming up to visit with us in Grand Cayman soon. I want to thank the team for inviting me, and I really want to thank the folks from the Massey Learning Institute for highlighting this really important women's issue. So I'm going to try to click forward here on my presentation. You see the next slide? Yes?
We are.
Good, okay. So just a couple of very, very quick things, and I'm going to spend a lot of time just discussing additional information than what's on this than what's on the slide. But the definition of menopause. So natural menopause is defined as the permanent cessation of menstrual periods, and it's determined retrospectively. I often joke with my patients that their last period doesn't come with a sign or a flag that says, oh, this is my last period. So you don't know that you're actually having your last period until you've passed that period of time, which is 12 months, determined retrospectively of amenorrhea, which means no menses, without another cause of having a problem. So 12 months around the age of menopause with no menses kind of defines the age of menopause. And natural menopause happens roughly at the age of 51, although there is a range of normal. And this is really important to understand the biology of human beings, which is that everything occurs in a spectrum, everything occurs in a range. There is no absolute number, no absolute time period that dictates that this is the perfect time or the best time. There is just what we have as the most common time, which is around the age of 51. But natural menopause can occur really anytime from 45 to 55. So someone going through menopausal symptoms at, say, the age of 46 is normal. And someone still having periods at the age of 54 is also normal. So there is an average of 51.4 years of when women will go through menopause and stop having periods for that important time frame of 1 year. But it's important to know that there's a range. And the reason that this happens is because the ovaries fail and there is near complete or almost complete follicular depletion, resulting in low estrogen levels. And along with low estrogen levels comes high FSH concentrations. And follicular stimulating hormone is actually the hormone that we measure to check to see if a woman is in menopause. So I give that out to you as an important lab value, because checking that hormone level, FSH, is often done by physicians to confirm that someone is in menopause. So again, there is a range of normal of FSH when a woman is having normal menstrual cycles. But then when the FSH goes really high, over the level of 30, that would designate that the patient has now undergone menopause. And if someone is unsure if they're in menopause, the FSH can be checked. Now, if the FSH is fluctuating in a number below 30, it doesn't mean anything, because there's great fluctuations during the menstrual cycle of FSH. But if someone has had no periods for, say, 9, 10, 11 months, they're having all of the symptoms, and they think, wow, can I confirm that I'm in menopause? I have not had a period for 10 months. Does it seem like I'm getting there? And they go to their physician for a regular checkup, and the physician checks the FSH level, and the FSH level is super high, much higher than it would be during the normal menstrual cycle. That's a pretty good indicator that the patient is in menopause. So again, from this slide, the take-home message is Missing periods for 3 months, 6 months, 8 months, but then having regular cycles kick back in is not menopause. And the important thing is you have to have the absence of menses for 12 months. And the other important take-home message there is if you've had no menses for 12 months, and then suddenly you happen to have a bleed, it could be a rogue ovulation, and actually just maybe one last sputter from the ovaries, or more importantly, physicians would look at that as post-menopausal bleeding. So say you've had no periods for, let's say, 14 months, and now all of a sudden you have what you think looks like or seems like a period, that's not actually a period. It could be something problematic and needs to be checked by your physician. So postmenopausal bleeding or bleeding after the absence of menses for 12 months is not normal and needs to be investigated. I'll move on to my next slide. So there are kind of 3 general groups of menopausal symptoms. And probably the most common, talked about, experienced, and seen by others, the one that is really the most, like the marquee symptom, let's say, of menopause are hot flashes or hot flushes. 80% of women undergoing menopause will experience hot flushes or hot flashes. So it's very, very common. The flip side of that is that 1 in 5 women will not. So sometimes people will say, well, girl, you got a real easy ride. You didn't have to experience any hot flashes. And that does happen for some patients. So again, there is a range of normal. And if you don't experience hot flashes, it doesn't mean that you're not in menopause. It means that maybe you're just in the very lucky group of 1 in 5 women who don't have to have the joy, or let's say the pain of going through hot flashes. And hot flashes, we'll talk a little bit more about them in a second. The second most common group of symptoms are genitourinary atrophy symptoms. So this is where the reproductive tract begins to display or undergo the symptoms of having lost estrogen, because estrogen is really, really important for the health of your reproductive system. And of course, by the time women are going through menopause, reproduction and having children is really not top of mind. So things like the uterus, the cervix, the ovaries, the internal organs, not so important anymore, or not at the forefront of people's minds, but certainly the external organs and the organs most important for sexual function are the ones that really display the outward manifestations of lacking estrogen. So without putting up any graphics or diagrams of female genitalia, let's just say that the external genitalia of women, otherwise known as the vulva, or the labia, do undergo some atrophy. Atrophy is shrinkage. They become less resilient. They are less able to cope with the mechanisms of intercourse. And then most importantly, the most important organ for intercourse is, of course, the vagina. And women's vaginas do undergo changes as a result of menopause. So in early reproductive life, the vagina has a lot of ribs in it. Those ribs are called rugae. Those rugae are normal, and they are involved in a healthy vagina that has a lot of estrogen. What happens when a woman loses those estrogen over the years after menopause, the rugae flatten out. So a physician, a gynecologist examining a patient could probably look at a patient's vaginal health and see right away whether a woman is premenopausal or postmenopausal, because a vagina that is very pink inside, where there are lots of ridges and rugae, is a woman who is premenopausal, and a vagina that is more white and flat and smooth and lacks pinkness and lacks those ridges is most likely a postmenopausal vagina. And those changes don't happen immediately overnight. They happen with time, and they continue to happen into the postmenopausal years. So importantly, vaginal atrophy symptoms include vaginal dryness. And we're not just talking about dryness associated solely with sexual function or solely associated with getting excited or being turned on for sexual intercourse, but many women will experience vaginal dryness that is uncomfortable in their normal daily lives. And this is a very uncomfortable, off-putting feeling for many women. Um, as a man, I will never be able to experience this, but having taken care of thousands of women who have gone through menopause, a lot of them will describe it as having a kind of a feeling of cotton mouth, where you lack saliva in your mouth. So you see, I'm speaking to you right now, and I'm seeing 97 attendees, and I have my little bottle of water next to me here, because when I get a little nervous and I'm talking to a lot of people, your mouth gets dry and you want to have a sip of water as you're speaking. Now, if my mouth got very, very dry, my ability to speak properly and to form words would change, because you need saliva in your mouth to speak properly, and you need saliva in your mouth to swallow food. Well, the vagina needs moisture, and it needs secretions, not just for sexual intercourse, but just for normal feeling and normal function. And during menopause, those secretions can significantly decrease. And the feeling of dryness in the vagina can be very, very uncomfortable and off-putting. Painful intercourse, which is called dyspareunia, which is the medical word for painful intercourse, most often happens because of vaginal dryness. And then, in addition, sexual dysfunction, because the vulva, the labia, the clitoris, and the other external organs involved with intercourse change and become thinner and become less resilient. So the vagina and the vulva of a 26-year-old are very different to the vagina and the vulva of a 56-year-old or a 66-year-old. And those changes are the results of losing estrogen. The third one is mood symptoms. And there is a certain amount of emotional lability and mood changes that do happen with menopause. Women will feel that they are increasingly, their mood is increasingly volatile. But I want to speak to that and suggest that a lot of data says that yes, there is mood dysfunction that happens over the course of menopause. However, I would like to put out there that there is an additional reason that there may be mood dysfunction in menopause that is not related just to psychological changes. So hot flashes, back to the one at the top, hot flashes are most often sensed by patients at night. Now, that's not because they occur necessarily more frequently at night, but in the busyness of your day, in the busyness of your work, in the busyness of your job as a Massey employee, as a mother, as a spouse, as a child taking care of older parents, and so on and so forth, you're kind of more focused on the activities of your daily life, and you're less likely to focus on inward symptoms. But then when you start to power down at night and try to get some rest, that's when you might begin to sense the hot flashes more frequently. And the difficulty with hot flashes is that they can wake people up from sleep. And every woman in the room who may be perimenopausal or postmenopausal on this discussion knows exactly what I'm talking about. So we're talking about sometimes not just being woken up from sleep, but we're talking about drenching sweats And this is very difficult for men to comprehend, because they will have a situation between two partners in a bedroom where the husband is under the covers and the air conditioner is on full blast and he has covered over trying to cope with the cold, and his wife is lying next to him in the bed absolutely burning up in the middle of the night, and she has now thrown off the bedclothes, thrown off the blanket, taken off her pajamas, and she is drenched. And women who experience this are actually getting up out of bed and having to go and shower off or dry off in the middle of the night. Now imagine if that were happening to you every night, or even 3 or 4 times a week. Guess what's happening? Your sleep, your rest is being disturbed. And therefore, I know when I have a night of disturbed sleep, the next day I'm not at my best. So imagine if that now is happening more frequently throughout the week. You now have a chronically exhausted woman. And that chronically exhausted woman is now not concentrating well, not at the peak of her game, and probably more irritable than she otherwise would be. So the mood symptoms are both an effect of psychological changes and changes that do happen as a result of going through menopause, but they are also really related to disturbed sleep. Hot flashes occur, only 20 or 30% of women will actually seek medical attention for hot flashes. And the typical symptom, as I described, is this sensational heat that comes from inside the chest and face and then spreads throughout the body, and as the slide suggests, can cause significant sleep disturbances. Now, again, getting back to the fact that everything in human biology is on a spectrum, there is no absolute normal way in which these symptoms occur. In fact, we know from research that there are actually 4 very different trajectories of menopausal symptoms, and they occur in roughly about the same percentages, give or take a little. So the first group are women that will start to experience these symptoms way ahead of the cessation of their menses. So they may not, you have to remember, you don't stop having the periods and then the symptoms come. It's all kind of happening together. So sometimes women are starting to skip periods and starting to go for 3 and 4 months without a period, and then they'll have some more periods, and then they'll sputter into 6 or 7 months. And of course, as we talked about earlier, 12 months is the actual definition. But while that is happening, there is a subgroup of about 20% that are going to experience these hypoestrogen symptoms right away. And it's going to come on fiercely from the very beginning of the skipping of the period. So about 20% of patients are going to sense this from the very early get-go. Then there's some that are only going to experience these symptoms near the final menstrual period, when that last period comes. And of course, we don't know that it is your last period, but it's right at the end when you finally stop. And then there's the early onset with a really high frequency. So not everybody starts getting hot flashes and experiences an uptick in their hot flashes as they go through menopause. Some women start getting terrible hot flashes all of a sudden out of nowhere, and the frequency stays high. And then, as we talked about, there's some women who have almost no hot flashes at all, so very low frequency. So there are different paths and there are different trajectories to these symptoms. Well, let's talk a little bit about the management of hot flashes. If someone has mild symptoms, they're not being woken up at night, they're not missing sleep, and the hot flashes are manageable. Let's say a patient who's having maybe 1 or 2 per day. You know, all of you are Massey employees, you have to be in various meetings, you have to be interacting with vendors on the outside, interacting with each other in meetings. You know, you have a hot flash here and there, you feel a little warm, you might get a little touch of perspiration, and you can kind of pass it off. That may be someone who is more or less in the mild category. Imagine somebody that is on a presentation like this, trying to give a presentation, and all of a sudden they literally in front of you become drenched in sweat. I have actually seen this many, many times with my patients and witnessed it when they're in my office. And they say, Dr. Gatcliffe, come and see, let me show you something. Look at this, I'm having a hot flash, I'm having a hot flash. And I say, I can see it, because they become visibly red, visibly flushed, and literally start to perspire like they had just run around the savannah. So this is really, Bajans, you all know what the savannah is? You're laughing. We have a big park in Trinidad called the Savannah. That's what happens with Carnival. You all know Carnival goes through the Savannah, right? You're running around the Savannah. The Savannah is a 3-mile run in Trinidad and Tobago, in the capital. I have to remember that not everybody here is in Trinidad, right? So as if they were running the Savannah. So it looks literally like someone just breaks out in a terrible, terrible sweat. And that is very, very, very off-putting. So that kind of symptom is a very severe symptom, and there's two kinds of treatments for that. One are hormone therapies, so replacing the hormones back to the patient, and the other is non-hormonal options. And we could talk for about the next 2 hours on which are the ones to choose and which are the ones not to choose. And I'm hoping that we will get into a discussion about that together. The hormonal therapies involve taking estrogen back into the body in various ways. If a patient has a uterus, that estrogen needs to be balanced with progesterone. So anybody who goes to a medical provider, even a gynecologist, who has a uterus, who still has a uterus and has not undergone, for one reason or another, a hysterectomy, has to be put on estrogen plus progesterone. You have to have the balance of the progesterone with the estrogen, else you could end up with some serious problems in your uterus. And we can discuss that in the questions. For women for whom estrogen replacement therapy is contraindicated for any number of reasons, such as they have had blood clots in the past, they have had problems taking estrogen, they have an estrogen receptor positive cancer, such as breast cancer or certain kinds of breast cancer. Not all breast cancers are estrogen receptor positive, but some are. Those are patients in whom you would want to avoid hormones, and you'd want to use some non-hormonal options. So I think I'm pretty much close to wrapping up. I just wanted to show you guys a picture of the hospital in Grand Cayman where I work. And also, I wanted to show you our new hospital, which hopefully a team from Massey can come and visit. This new hospital is actually in the capital. It is opening in July, a month ahead of schedule, and we are hoping to have a group of you guys come and see our new operating rooms and our new hospital in Grand Cayman. So with that, I'd like to wait. I'd like to stop and allow for questions.
Fantastic. Dr. Gatcliffe, thank you. I know we had a rough start, but thank you so much for that presentation. I know a lot of it will hinge on the questions that we have today from the men and the ladies, or the other way around, the ladies and the men. Yes, because we have supporters here who want to know. But you know, sometimes as females, we believe that we know everything we should know. And I certainly learned some very interesting things from the presentation. So I'm going to ask Renee Barnett to moderate the questions in our Q&A segment. Renee?
Good morning, everybody. Thank you so much, Dawn. Thank you so much, Dr. Gatcliffe. All right, so our first question this morning. I am currently 45 years old and had a hysterectomy at 44 as a result of adenomyosis. And I have experienced the hot flashes and currently experiencing sleep disturbances and mood symptoms. It is quite difficult navigating these. My question is, will I continue to experience this at a later age as well?
So great question. So in general, menopausal symptoms do abate and they do lessen with age. But again, as we spoke about before, every woman's path through menopause and into postmenopause is very different. And the important thing to know is that if your menopausal symptoms continue to be very bothersome to you, no matter what age you are, you should probably seek the help and advice of a physician and discuss what kind of medications or opportunities for dealing with those symptoms are available and applicable to you. So there are patients who have a rough few years and then the symptoms get less. There are patients, for example, like my own mom, for who their symptoms go on way into their 60s. So again, there is no way for us to know. There is no way for us to test. There is no way for us to predict what a woman's personal individual journey through menopause would be. All I can say is focus on your own experience and address your symptoms with a physician if they are bothersome.
All right, excellent. Thank you for that response. Moving on to our next question. What can you do to regain estrogen?
The only thing that you can do to regain estrogen is replace it. So there is no way to reinvigorate the ovaries. There's no way to re-stimulate the ovaries. There is no way to get your body to go back to producing premenopausal levels of estrogen. I am sure that somebody in the lab, in the world, is in a lab working with some ovary cells and trying to see how they could maybe get postmenopausal ovarian tissue to go back, but this is programmed into your body by nature. And whether you believe in the grand design, whether you believe in God's providence, whether you believe in this is the way we were meant to be, or whatever it is, however you want to look at it, women go through this change and their ovaries ultimately fail to produce high levels of estrogen. And there is no way to really get them to kickstart back into that. So hormone replacement therapy, HRT, is a whole field, a whole area of expertise. And you can only get back menopause, get back estrogen by taking it exogenously. Endogenous estrogen production goes down and stays down after menopause.
Thank you. We have two follow-on questions from that. Why should estrogen and progesterone be balanced? And does estrogen treatment cause cancer?
Wow, that's a great question. So let's get a little bit, not too much into the weeds, but let's get a little bit into the physiology of the menstrual cycle. So everybody knows that they have two hormones that are involved in your menstrual cycle, estrogen and progesterone, that are produced by the ovaries. Estrogen and progesterone are like the yin and the yang of the counterbalance of the hormones that are needed to prepare the uterus every month to become pregnant, because that is what your body is doing each month, preparing to become pregnant. And then pregnancy does not occur, that lining can't just continue to stay there waiting for whether you're going to become pregnant the next month, the next year, or whatever. So progesterone is the balance to estrogen, and it is the balance that comes from progesterone that causes the release of that lining and a menstrual period. All right, so estrogen builds up the lining, progesterone causes the lining to be released and sloughed off in a monthly fashion, which is what a menstrual cycle or menses is. Now, if you took estrogen and you had no progesterone, the lining would just build and build and build and build. And it wouldn't build until, the uterus exploded, but it would build until the lining started to become dysfunctional. the lining started to undergo changes that were not productive, because the lining is only meant to hang around in your uterus for roughly a month. So after that month, the lining becomes no good, and progesterone is required to help that lining slough off. So now let's fast forward to menopause. If you take estrogen, one of the side effects of taking estrogen, not just to deal with your symptoms, but the estrogen is also going to stimulate your uterus to build up a thin lining. Okay? And again, if you remember what I said about that lining is A, not meant to be there after menopause, and B, is not meant to last more than a month. So if you don't take progesterone to cause that lining to slough off, or at least to not turn into something bad, you can end up with precancerous cells, or you could end up with actually an endometrial cancer. So if you have a uterus, taking both the estrogen and progesterone is really important. And I see patients go sometimes to physicians, to healthcare providers, that forget that they have to give a patient with a uterus both estrogen and progesterone if they have a uterus. Now, if you don't have a uterus, there's not going to be any problem in the uterus as a result of taking the estrogen, because you can't get a problem in an organ that you don't have. So therefore, you don't need to take progesterone if you don't have a uterus. Now, to the second part of the question, can estrogen cause cancer? Well, estrogen, hormone replacement therapy, or taking exogenous estrogen from the outside into your body, whether it's by a pill or a patch or other means, can cause cancer. And the risk of cancer increases with age, but the overall risk of it causing cancer is really, really low. So statistically, the chance that it's going to cause a cancer in your body is quite low, but there are some patients for whom that risk may be higher based on various genetic predispositions or based on various personal things that are going on in their body. And therefore, anyone choosing to take hormone replacement therapy first has to be counseled very carefully about the side effects of taking hormones. And the two most common cancers associated with taking hormones are endometrial cancer, as we've just discussed, and also possibly breast cancer. And when you hear that, you're like, oh my gosh, well, if this could cause breast cancer or this could cause endometrial cancer, why would I ever want to do this? Well, like I said, the risk overall is very, very low, but it's not zero. But for a woman experiencing terrible symptoms of menopause, the taking of hormone replacement therapy can make her feel so much better and revolutionize the way she feels, that for that individual patient, the benefits would outweigh the risks. So it is a very important individual discussion that has to be had between the patient and her provider.
Wow, thank you so much for that thorough response. Thank you, thank you. All right, moving on to our next question. Is there an equivalent for men, male menopause?
Well, this is a great question. And, you know, lots of jokes are made about menopause, and lots of jokes are made about men and women and the fact that women suffer this change. But I'll share with you something. I'm a 54-year-old man. And I'll tell you something, I'm not the same man I was when I was 26, not in any way, shape, or form. So there's not exactly the equivalent in men. Testicular production of testosterone does not drop precipitously at a certain age. However, there are normal changes that go on throughout a man's life that also place him in a very different place in his 50s and 60s and 70s than when he was in his teens, 20s, 30s, and 40s. So is there really an actual equivalent in men? The scientific answer is no. But the kind of general answer, I feel, is that while there may not be a menopause per se that equates to what women experience, men do undergo significant changes in their body. in their sexual function, in their testosterone levels, that occur throughout the course of their life. So whilst it has been known since man stood on 2 feet that women will stop ovulating eggs at menopause and therefore are considered technically sterile or unable to reproduce after menopause, and we know that men continue to produce sperm up until the day that they die, the sperm production, the testosterone production, the ability of the way a man performs sexually is not the same when he's 60 as when he was 20. So there are definitely, I think, some parallels that happen between both men and women, although exactly an occurrence of menopause where testosterone production drops like estrogen does, there is not that equivalent.
All right, thank you so much. Moving on to our next question here. I had a hysterectomy in June 2023, almost 1 year ago. I have very few symptoms now. Hot flashes are very mild and almost non-existent. Is this the calm before the storm? Would my symptoms get worse with time? I am 2 years old now and was having a regular period every month before my surgery.
So just to clarify, I want to make sure that I have it correct.
Mhm.
Hysterectomy, and this is something that I talk with women every day in my office when I'm counseling them for surgery. Hysterectomy is removal of the uterus. Removal of the ovaries is often done at the same time, but it is a separate procedure with a separate name. And there is a huge misperception. So maybe you want to tap back into that person asking the question and ask them, at the time of their hysterectomy, were their ovaries removed? And perhaps they were, and that's why they're asking the question. And it's a legitimate question, and I'll answer it. But I just want to talk about the fact that hysterectomy is most commonly misunderstood, even by women who have had the procedure, as being, quote unquote, removal of everything. So hysterectomy is the medical term for removal of the uterus. Bilateral salpingo-oophorectomy, which is removal of the tubes and ovaries, most importantly, bilateral oophorectomy, is often done at the same time for women depending on their age. But not every woman who has undergone a hysterectomy also had her ovaries removed. So the question is when you had a hysterectomy, were your ovaries removed? Now, to answer this employee's question, I think I'm talking to patients all the time. I'm so sorry. To answer this lady's question, if she had a hysterectomy and her ovaries were definitely removed at the same time, and it seems like so far her symptoms are mild, then it would appear that she's in the lucky group. Because if it's 2023 and we're now a year later and she has not experienced terrible symptoms yet, then she probably is not going to experience terrible symptoms. Now, the reverse is if she had a hysterectomy but her ovaries were left. Remember, now with no uterus, you don't know when your periods are stopping. You no longer have the signal of your menses going away. So the only way that you might know that you're starting to go through menopause is by starting to experience mood symptoms, vaginal atrophy, the symptoms, the sexual side effects, and the hot flashes. So without a uterus, but with your ovaries still in place, you no longer have the ability of your uterus and your period to tell you what's kind of going on with your body, other than experiencing these symptoms. So it might be the calm before the storm. Or maybe you're not even really in menopause yet and your ovaries are still functioning well. One thing that could be done if you think you might be is the FSH level can be checked by your doctor.
All right, great. She's one of the lucky ones then. All right, moving on to our next question. I'm 44 years old. My period is now delaying from 24 days to 36 days. Are these early signs of menopause?
How old again? I'm sorry.
44.
44. So perhaps, but not necessarily. So again, women get, because unlike men, women are so tuned into their bodies, so tuned into their menstrual cycles. A lot of women fail to be properly counseled by their physicians that the period that you have for most of your life is not necessarily the period that you're going to keep until the day you go through menopause. So there are changes, and those changes are also normal. So if you now start changing your cycle from a textbook every 28-day cycle, but you now start having every 36 days or whatever it may be, but every 36 days that period is still coming regularly, that may just be your new pattern. The key is where you skip periods. I think you're beginning to go into menopause when you skip periods for a month or 2 or 3, or you go through a significant number of months with no period. That's probably the sign that you're starting into the process, not just the lengthening of the period. So again, not everybody has a period that starts when they're, 12 or 13 or 14 or whatever the age might be, and it stays the same for their whole life. A lot of women will know that their periods are different as they went through their life. So for some people, it is exactly the same up until they go through menopause. But for other women, cycle length will change, and that is also normal.
All right, thank you. Moving on nicely to our next question. Is there anything that a woman can do to treat atrophy of the vagina?
I'm so glad that someone asked that question. So one of the hardest things to counsel women about is the whole concept of hormone replacement therapy, and HRT on the whole, when we talk about HRT, hormone replacement therapy, to deal with symptoms like hot flashes and so on, means taking systemic hormones, either by patch or by pill. And those are hormones that go into your bloodstream and therefore affect your whole body. Now, if a patient has just vaginal dryness, vaginal atrophy symptoms, estrogen can be given just to the vagina in a cream or an ointment or an ovule without going into the patient's symptoms, into the patient's system. So this is a really, really important distinction, because if, for example, a patient has had a stroke in the past, has had an estrogen receptor positive breast cancer, had a clot in the past when she was taking birth controls, or has otherwise a contraindication to taking estrogen, and therefore cannot take HRT, systemic estrogen, but has really bad vaginal dryness, estrogen can be given just into the vagina to reinvigorate the health of the vagina and help with vaginal dryness, and that is not HRT, because that does not get absorbed systemically. That just affects the vaginal tissues and the vaginal mucosa without the risk of HRT. So it's a great question, because when patients come and they cannot take estrogen for a medical reason, or they don't want to incur the risk of taking systemic estrogen, but they want to deal with the vaginal dryness symptom, we can give them estrogen, and that estrogen just deals with the vagina alone. And it's either by a cream, an ointment, or an ovule placed into the vagina, and it changes the symptom of vaginal dryness significantly.
All right, wonderful. Thank you so much. Moving on to our next question. I know it's 11:02, but if you do have the time, we invite you to stay on just a few more minutes.
Sure, I'm looking at my thing here, because I'm actually doing surgery not long from now, but so far they're not calling me yet, so I'm more than happy. I have a lady with a placenta problem, so the obstetricians are delivering the baby, and that's why I'm in my coat and scrubs as you see me here. Else Amanda would be like, Dr. Gatcliffe, you didn't put on a jacket and tie for us. I know that Amanda is watching me very, very, Mr. McMillan is watching me very closely. So normally I would have showed up in a jacket and tie, but I'm about to go to the operating room. So this young lady is having a cesarean section, and then she has a problem with her uterus. So we're going to do a hysterectomy right after. So they'll be calling me shortly, but so far so good. Let's do another question.
Okay, great. Thank you so much. We appreciate it. All right. What can you take to regain your sexual drive?
Wonderful, wonderful question. You see, most of the good things come from the questions. You're right, Dawn. So this is a huge topic. We could talk on a whole different day about it. But interestingly, sexual drive or libido, as it's called, or sex drive, is the result of testosterone in both men and women. Lots and lots of women fail to understand that their sex drive also comes from testosterone. And this may be news to several people on the call. We still have 98 attendees. This is a hot topic. Only 2 people dropped off. Wow, that's great. So women make testosterone as well. And women have receptors for testosterone in their bodies as well. And women have an entire testosterone homeostasis that is responsible for their desire and their drive. It just acts in a different way and through different mechanisms in a woman than it does in a man. Men have very different levels of testosterone. So men that need to take testosterone replacement therapy when a man loses his testosterone for one reason or another, take it in different doses. However, sexual drive, sexual desire, and libido in women is also controlled by testosterone. And if that becomes the major symptom of menopause that a patient is experiencing and the most bothersome thing, testosterone replacement therapy, appropriately given and appropriately dosed for a woman by a provider who knows what she or he is doing, is the best way to regain libido.
Thank you for that tip. Thank you so much, doctor. All right,
Now,
do we have time for one more?
I want to just throw in one thing there, right?
Mm-hmm.
Most people who are in midlife are usually partnered in some way, whether it is through the convention of marriage, whether it is through a civil partnership, or whether it is just someone with whom they are in love. And therefore, sexual function is a couple's issue. It's not just an individual issue. And the one thing that I want to say about sexual function and sex drive and libido issues as they relate to a couple is that when you are undergoing issues to do with sex drive in a partnership, it is really, really important before going out on your own and choosing to go on to some kind of hormone replacement therapy that you discuss and understand what is going on in your personal sexual relationship with your partner, your husband, your wife, before making a unilateral decision. Because you have to remember, like we talked about, men may not have a menopause. However, a man who is 20 and a man who is 58 are 2 very different men. And so therefore, before either partner considers taking exogenous hormones, they should have a discussion about that. You should need to have an intimate discussion about that with your partner. Because in the 50s and in the 60s, in those decades of life, intercourse, sexual function, and sexual well-being are very different to when you're in the earlier part of your reproductive life. So I always tell people, have you spoken about, well, my patients are all women. So I always say, have you spoken about this with your husband? Have you spoken about this with your life partner? Are they aware and are they ready for you to make changes? Or is this something that maybe you just need to work through together before doing something like going on to a hormone? So I'll just kind of put that little caveat in there. And we'll take one more question.
All right, great. Thank you so much. Let's go down here. Are there supplements that can be taken prior to menopause?
Supplements that may do what? Stave it off or keep it away? No. So your body is programmed to go through menopause, and there is nothing that you can do that is going to stop that biological occurrence from happening. So should you take care of yourself? Should you eat well? Should you get enough sleep? Should you consider a multivitamin? Should you keep yourself in good shape? Absolutely. For all of the other reasons, not just sexual function and not just for being well in your late 40s and early 50s. But is there anything that you could take that will stave off, hold off, or stop you from going through menopause? No.
That'll be a top seller if there was.
Well, it would rival now the world's most popular weight loss drug, which is Wegovy. Wegovy is going to become the largest selling drug on the planet very soon, you know.
Wow.
But if anybody could find a way to stop menopause from happening, can you imagine? Oh yeah, I think it would go past the weight loss drug.
All right, if you don't have any more time, I'm going to hand back over now to Dawn to wrap it up.
Thank you, Renee, for moderating. And Dr. Gatcliffe, I know you have to run, but we definitely need a part 2 to this. We definitely, so we will be having you back. So everyone in the audience, just get ready. We will definitely be having the doctor back because there are a lot of other questions that we didn't get to today. We really appreciated your responsive, Dr. Gatcliffe, to our questions, your knowledge and the care you took in answering the questions posed, particularly on the topic of estrogen and hormone replacement therapy, and that it really is a conversation for our women and our doctors. Each person is different. We really had a great, great discussion. So I'm going to be welcoming you back in good time. A special, special thank you to Amanda Macmillan and the Wellness and Benefits team who collaborated with us here at MLI to bring Dr. Gatcliffe to our platform. Thank you so much for working with us. And to you, our audience, you really made today with your questions and just opening up and really getting to understand something that happens during all female lifetimes. So thank you for helping us today to really make this great. And it's so, well, I don't want to say so sad, but we've come to the end of our webinar today on navigating menopause, what every woman needs to know. Thank you for joining us. Look out for more of such topics and a continuation of this topic. And other things to look out for, I really want you to take a look at our June calendar, Unlocking the Power of Power BI, Introduction to Business Analytics. And of course, for those of you who are interested in upping your game as middle managers, our new cohort will begin soon, so take a look at that. And our next webinar will be on May 22nd as we join our team and looking at our Forces for Good presentation on ESG and care, Massey Care. So until next time, remember, level up always, and bye-bye for now. Take care.